My name's Kate Wakelin and I'm from the Cancer Council Victoria. We're just sorting out a few technical issues before we kick off the webinar at 7:30. So feel free to go and grab yourself a cuppa and we'll be with you very soon.
Can I ask a question?
Yes,
Do
sure.
I need my webcam on?
You don't.
Because I've logged in, but...
And can I ask who's speaking?
My name's Diana Locke.
Okay, Diana. I can see that you're in the webinar, so I can see your name there.
Yep.
You don't need a webcam, so we've got about 50 people coming along tonight, and we're not going to have 50 people up on the screen.
Oh, right, okay.
So it's just the presenters who will have their webcams on, and we've just got one final presenter who's in transit from the airport, Dr. Nick Pavlakis, and he'll be with us very soon.
Okay. So I just stay on the phone, is that right?
That's right. So, and this is probably useful for everybody else to listen to as well. The audio for this webinar will be delivered via your telephone. Mm-hmm. So great if you can just listen in via your phone.
Yes.
And the visual part of the webinar, which is what you can see on your screen, will be on your computer. So we're just waiting for people to filter through. Okay. And what I might do is actually, once we start, I'll actually give everybody some instructions about how to mute their phone so we don't get lots of background noise during the webinar. Mm-hmm. While we're setting up, we're just going to be making sure all of the presenters' slides are working properly. Okay. But the other thing, just to let you know, is that to communicate with people during the webinar, on the bottom half of the right-hand side of your screen, there's actually a messages section there. Okay. You can actually use that to communicate with us and actually with each other if you'd like to. That's fine too. So that's just typing into your computer keyboard. Yep. There's a little box down the bottom that you can see that you can type into, and when you press the enter button on your computer, that will send the message through.
Okey-doke.
So... what we might do is, just while we're still waiting for our final presenter, is and I can just hear some new people coming in, and I can see some people have done some messaging, which is fabulous too. So what I'm going to do is just test out the presentations. So the first person who will be speaking is Rod Hicks. So, Rod, I'm just going to get your presentation up on the screen so you can see it there. How does that look to you?
Looks fine. Thanks, Katie.
Fantastic. Okay, and you know how to progress the slides, etc.
I do.
And I'll just make sure that I can put up Nick's slides, which is fine too. So that's good. And Rich, I'm just going to bring up your slides. And Rich, you sent me through some last-minute alterations.
Just one little insert, yeah.
Yep, and I've got that in there now, so that should be fine. So you can see that up on the screen, all right. And Simone, I'm just going to test out your one. I can hear more people joining us, which is fantastic. So that's fine. That's your presentation up there on the screen. So
great, thank you.
We'll just minimise that down for the time being, and then the last one will be mine. Okay, so look, anyone who's just joined us, feel free to grab a cup of tea before we start. We're just tidying up any technical issues, and I think we'll be ready to go at 7:30. Yeah. I was just telling people earlier, for those who've just joined us, that there's a text box on the right-hand side of the screen, just at the bottom half, where you can actually type in messages. You can type in messages to the presenters if you've got questions along the way, but you can also use the box if you want to, ask questions of each other too. And we'll just keep an eye on those messages as the webinar progresses, so that we can have a look at the questions as they come in, but hopefully there'll be some other conversations going on at the same time. So just excuse me while I have a drink, and just about 4 minutes until we get going. So it's Kate from the Cancer Council Victoria again. what I'd like to do is get all of the participants who are not presenting tonight to actually mute their phone, and that will just help us with some of this background noise that we're experiencing. So the way that I will get you to do that is on your telephone keypad, if you could press the star followed by the 6. So just, and then it should help us with background noise that we're getting. You can see, Diana Locke, you've said cold in Melbourne. It sure is. I'm just wondering, while we're waiting for people to log in these last couple of minutes before we get going, perhaps I can see a few people have seen the messages box, but it would be really interesting to hear where other people have logged in from. So feel free to find that text messaging box down at the bottom right-hand side of your screen, and maybe let me know where you've logged in from tonight. And for people who've just arrived, what we're getting you to do is just to mute your telephone line so we don't have a lot of background noise in our teleconference tonight. So the way we do that is to press the star and then the 6 on your telephone keypad. So I can just hear people log. When you arrive, you could press the star and then the 6. And I'm just going to pop a message in the text box about that too.
Hello.
I can hear someone's joined us, and welcome. It's great to have you on board. What we're asking people to do if they're not presenting tonight is actually to press the star and then the 6 on your telephone keypad. And what that will actually do is mute your phone so we don't get a lot of background noise during our webinar this evening. So I can see that there's quite a few people who've popped in where they're calling from. So I've got Gold Coast and Marion in South Australia and Brisbane, Sydney, Melbourne. Where else can I see people have logged in from? Gold Coast, Phillip Island. Oh, brr. It would be cold down at Phillip Island tonight. And very wet in Port Macquarie, we're seeing. So it's great to have people dialing in from all over the country. It's very exciting. So just a minute or so, and then we'll get going. As I said earlier on, for people who've just joined us, that text messaging box is for us to communicate with each other during the webinar, but it's also great if we can use that to ask the presenter questions. And that leads me on. It's great to have had people submit the questions via email. I can hear someone with an echo, and I know everyone else will be hearing that too. But I'll remind people, if you're not presenting tonight, if you could just mute your telephone, and the way to press the star and then the 6 on your telephone keypad. So we've had heaps of questions. We'll be attempting to answer at least some of those questions during the presentations, although I suspect that if we looked at, I've just got the page up in front of me, and there's pages of questions, so which is fantastic. And what that tells me is there's a lot of information that people really do need about neuroendocrine cancer. So we'll attempt to answer at least some of those tonight. Sounds like there's plenty more conversations to be had for the future too. So maybe we'll get rolling at 7:30, and I'm keen to get the ball rolling. So thanks everyone for joining me. My name is Kate Wakelin, and I'm from the Cancer Council Victoria, and we're really proud to be partnering with the Neuroendocrine, the Unicorn Foundation tonight in presenting this webinar. And we're really grateful to Professor Rod Hicks and also Professor Nick Pavlakis, who will be sharing their extensive knowledge with us tonight, and also Rich Johnston, who's going to be coming in as a person who's experienced a neuroendocrine tumour, sharing some of his personal experiences as well. So I guess the first thing I will say once more, and I'm sorry to those who've heard me say this lots of times already, for people who aren't presenting this evening, it would be great if you could mute your phone, and that just helps us reduce some of that background noise that we can hear. To do that, you need to press the star key and then the 6 key on your telephone keypad. So if you're able to do that, that would be fantastic. I'll just also let you know that, as I said, if you're not presenting tonight, if you could just mute your telephone, and the way to do that is to press the star and then the 6 on your telephone keypad. So if you're able to do that, that would be fantastic. I'll just also let you know that, as I said, if you're not presenting tonight, if you could just mute your telephone, and the way to do that is to press the star and then the 6 on your telephone keypad. So if you're able to do that, that would be fantastic. you'll be able to see on the bottom half of the screen on the right-hand there's a messaging box, and you can use that to message each other, so to actually provide your reflections on what's being said, but also to ask questions of the presenters as we go. So we just encourage you to been trying that out so far, saying where they've come from. So great to have that up on everyone's screens. Thanks everyone who has submitted questions in. As I said earlier on, we'll be attempting to answer some, if not all, of those questions this evening during our webinar. Just a couple of other things. I guess really importantly this evening, there's people who've logged in from all over Australia, which is fantastic, and it's just really important for us to maintain what is a respectful atmosphere. So if you could just bear that in mind when you're commenting with people, and in your interactions with people this evening. So that's probably just about where. Here, a couple of other people have joined us. So just one more time before we hand over to Rod. I'll just ask anyone who's just joined us who's not a presenter if you could mute your telephone. And the way that you do this is to press the star key and then the 6 key on your telephone keypad. So I apologize to everybody for being quite repetitive with that. Now, I'm just going to check because I can... Pavlakis has sent me an email, which means that he's arrived home from the airport. He's got a very busy evening this evening, but I don't think he's joined us in the webinar yet, so he'll be with us very shortly. So what I'm going to do actually is, Simone, I'm going to hide everyone's webcams except for Rod, so I'm going to do that now.
Hi, everyone.
And is that I think someone else has just joined us there. What we're doing is just muting your phone if you're not a presenter, and the way to do that is to press the star and then the 6 on your telephone keypad, and that will just enable us to reduce any background noise. So without further ado, I'd like to re-enable Rod's... It's like being an air traffic controller, isn't it? I'm very sorry, everybody. We will be with you. We'll be getting going.
Hide me.
Fantastic. Rod, you're up there. So the other thing I didn't say is this is the first webinar we've run as Cancer Council Victoria. So if you hadn't guessed it already, this is a steep learning curve for all of us. So I'm really appreciative to everybody for your patience and for coming along on this mysterious new world that we're living in. So I'd like to, without further ado, welcome Professor Rodney Hicks to the webinar. And I'm just going to give you a little bit of a background about Rod before he gives his presentation. So Rod's a Professor of Medicine and Radiology at the University of Melbourne and the Director of Cancer Imaging at Peter Mac Cancer Centre in Melbourne, Australia. He's published over 250 peer-review articles and more than 15 book chapters, so I'm very happy that he's along this evening as an expert. A major focus of Rod's clinical research has been actually looking at the impact of PET scanning on patient management. In addition, he's actively involved in radionuclide therapy with a major focus on neuroendocrine tumours, which is why we're here tonight. Rod's group has pioneered the use of radionuclide therapy in combination with radiosensitizing chemotherapy, and he has more than 15 years' experience in treating advanced neuroendocrine tumours. So without further ado, thank you so much, Rod, for coming on board this evening. I'm just going to get your presentation up on the screen and invite you to share some of that with us tonight.
Yeah, thanks, Katie. It's really a pleasure to be here tonight, and I'd like to thank the Cancer Council Victoria, which are great supporters of patients with cancer in this space, and the Cancer Council throughout Australia is a great resource, and also to Simone and the great work that's done by the Unicorn Foundation in bringing this kind of webinar to increase the awareness of this disease to the wider population. I think it's really a great initiative, and thank you to you. So welcome everyone. It's really a great pleasure. Some of you, or many of you I know. It's nice to have you on the webinar, and some of you will have heard some of these messages before. For that I apologise, but it's always good to hear it a few times, and welcome back. In terms of understanding what I'm going to talk about, many of you will be aware that neuroendocrines are an uncommon tumour but they're not rare. Sorry, I'm automatically on forward. One of those teething problems. Can go back. As I said, it's an uncommon disease, but it's not rare. It arises from neuroendocrine cells, which are part of a very broad system of cells that regulate a number of biological processes in the body, most particularly the regulation of digestion. And many of the symptoms are related to dysfunction of the digestive system. These particular neuroendocrine cells are characterised by the fact that they sense chemicals in their environment and release chemicals back into the environment which affect the behaviour of other cells. We often say at medical school that when hearing hoofbeats, think horses, not zebras. But where I work, unfortunately, we have herds of zebras running down the corridors, lots and lots of neuroendocrine patients. As I mentioned, although it's an uncommon disease, it's not really as rare as we perhaps think it is. The data suggests that there is an increasing number of patients with neuroendocrine tumours out there in the society. These are the data from the United States showing that over the last 40 years or so, there has been an increase every decade in the incidence or apparent incidence of this disease. Now, this may be related to better diagnosis or a true increase in the number of people with this disease. But it does look as though it's becoming more common. And because patients live for a long time with this particular disease, there's actually more patients living with neuroendocrine tumour than living with esophageal cancer, gastric cancer, and pancreatic cancer put together. So there's very many patients who are suffering from neuroendocrine tumours. While these tumours are very, very slowly growing, they can be lethal. They do kill people. And one of the analogies that I often use with my patients is that these tumours are very like mistletoe on a gum tree, that there is a great similarity between the characteristics of these cells and the cells from which they arise. We call them well-differentiated cells because they look like the cells from which they came. Just like a mistletoe leaf looks very like a gum leaf, it's not until the gum tree gets sick that you can actually recognise that there's mistletoe. And these two trees on the picture there are outside my dad's house. They're river red gums, and both of them have mistletoe, but one of them, a tree surgeon decided to do very radical surgery on the tree to cut out all the mistletoe, and effectively ended up killing the tree and leaving only the mistletoe, whereas the other tree, my dad was one of the original tree huggers and got out in the park and stopped him doing any tree surgery, and that tree has survived very, very well. It certainly had some zero weed spray on the mistletoe over the years, but it's still a very healthy tree. Although we talk about neuroendocrine tumours with one word as though they're one disease, in fact, there are a large number of different diseases. We know of at least 14 different cells from which some of them are normal hormones and tests and are named after the tumours like gastronoma or insulinoma, glucagonoma are known as those tumours because of the hormones that they produce in excess. But some of them are not functional. They don't produce hormones or chemicals that we can measure in the What I'm going to talk about primarily tonight are what we call the gastroenteropancreatic nets. That's tumours that arise in the digestive tract. These are primarily coming from the stomach, the pancreas, the small or large bowel, as you've seen on this slide. They're also known as GEP nets.
Rod, it's Kate speaking. I'll just ask you to speak up a little. It's just a little bit faint for me to hear, and it might be like that for other people too. I'm sorry to interrupt. And the other thing I would just say to people who've just joined us, we would just ask you to mute your telephones, please. And the way we'll need you to do that is to press the star and then the 6 on your telephone keypad. Sorry to interrupt, Rod.
I might go to speakerphone and see if that works any better.
That sounds pretty good.
How's that? Is that any better?
I can hear you. Maybe people can use their messaging to let us know if they can hear Rod okay. But keep going, Rod, and maybe you need to just hold the phone close to your mouth so that we can hear. Don can hear you, so that's good.
Okay, good on you. Okay, that's better. Sorry, I apologise if you haven't been able to hear me so far.
That's much better, thank you.
Okay, as I said, these tumours can arise from at least 14 different cells, mainly in the gastrointestinal tract, and some of them will produce hormones. The most common of them, and the one that I guess most or many people with NET would consider the prototypical example, is carcinoid tumour. This is now largely being replaced by the term small bowel neuroendocrine tumours. The particular cell that becomes malignant in carcinoid is a cell called the enterochromaffin cell, or EC cell, which is a really interesting cell at a microscopic level because it has lots and lots of different functions, one of which is to taste its environment. It has taste buds and smell receptors on the surface, and so when food enters into the bowel locally, it smells and tastes what's coming through. And it uses that information to regulate the behaviour of nearby cells, either directly through nerve connections or by secreting chemicals which affect their behaviour. They lead to the cells lining the bowel, releasing water and mucus to help the food move on, to release enzymes that help to digest the food. They also secrete chemicals that stimulate the smooth muscle in the bowel to contract and move the food on. And so when these cells become malignant and they produce the same chemicals in excess amount, they have the same effect, but rather than on a local level, they have it on a gut-wide basis. And so therefore, the bowel tends to pour out a lot of more fluid and to be much more active than normal, and that leads to the diarrhea and so forth that characterise carcinoid tumours. Many of these, the patients who have NET unfortunately present with very advanced disease, and so most of the patients that I see have already got widespread secondary deposits by the time that they've come along to see us. And that's because the symptoms of many of these neuroendocrine tumours are so commonplace that they get misdiagnosed as something else, as more common diseases. The diagnosis is often delayed. Things like asthma, irritable bowel syndrome, menopause, anxiety, food allergy, arthritis, and so forth. They're very common, and particularly for GPs in busy suburban practices, they would see hundreds and hundreds of patients with these symptoms every week. And to pick out the few patients that actually have carcinoid syndrome can be quite difficult in a relatively short consultation. And often that leads to patients, when they're finally getting diagnosed with NET tumours, to being really quite angry about their process and how long it's taken for them to be diagnosed. But when you stand back and look at it dispassionately, many of the symptoms that the patients have had, that they've ignored themselves for a long time as well, because they are often just seen as part of life. One of the aspects of these tumours that we use to both diagnose and to treat them is their similarity to the cells from which they arose. And while they have many different receptors on their surface which turn them on, like little switches that regulate their behaviour, they all share particularly common off switch, and that's called the somatostatin receptor. Somatostatin in Greek stands for body and stop, and so it's basically an off switch. It turns off the function of the cells. Although we think of it like a switch, in fact it's more like a revolving door that takes messages from the outside of the cell through the cell membrane into the cell to deliver its message. The naturally occurring peptide hormone called somatostatin has activity across 5 different classes of these somatostatin receptors. Commonly used drugs to treat the symptoms of these neuroendocrine tumours are called somatostatin analogues. They're copies of the naturally occurring somatostatin, but they have the advantage that they circulate for much longer in the blood. Because all neuroendocrine cells share a common off switch, it would be no use to have the somatostatin circulating around the body and turning off all the endocrine functions at one time. So somatostatin tends to be released locally and then to act locally on the cells, and it either turns them off or it's broken down in the blood. Whereas agents like octreotide and pasireotide, which are shown here and on the next slide, these are copies that circulate for much longer in the bloodstream. In fact, they've now been formulated so that they can be injected once every month or so and slowly released into the blood. And during that time, they bind to the receptor, get taken into the cell, and deliver the same message effectively that somatostatin delivered to the cells, which is to turn them off. And this can be very effective in reducing their hormone production. And there's also evidence that they may help to stop them growing. We can also use those receptors to diagnose it or to treat it using radioactive, what are called radiopeptides. The basic structure of these radiopeptides is essentially the same. They contain 3 parts: an isotope, a radioactive chemical, and there are 4 that we commonly use: indium and gallium, which are the top 2 on the slide, indium-111 and gallium-68. Which are primarily used as diagnostic agents, and lutetium-177 and yttrium-90, which are primarily used as therapeutic agents for treatment of tumour. Because they're metals, all those radioisotopes are metals, they can be bound to a linker, which is called a chelating agent. It's like a magnet that holds the radioisotope very tightly. And the 2 that are mostly used are DTPA and DOTA, and they're linked to a peptide, either octreotide or a related chemical called octreotate, which, as I've pointed out before, are copies of the somatostatin peptide, and they bind very tightly to this somatostatin receptor, and they get then internalized, taken into the cell, where they are either trapped and give off rays that we detect outside the body to give us a scan, or they deliver particles which deliver the therapy. There are 3 kinds of therapy we use. One is indium-111. It has a very ultra-short particle range. The particles are so weak that they barely get out of a cell. In fact, they deliver most of their radiation internally within the cell in which they're concentrated. And that's a good thing in terms of not giving any damage to nearby cells, but has the disadvantage that if there are cells nearby that don't have many receptors on them, there's no ability to deliver radiation to them by an effect that we call crossfire, where each cell bombards its neighbour. In terms of the ones that we use more frequently, lutetium-177 has a short particle range with particles passing 1 to 2 millimetres into the surrounding tissue. That's actually hundreds of cells, and because each cell will irradiate or give radiation to its neighbour, there's significant radiation to tumour deposits after they get above about 3 or 4 millimetres in size. And there's relatively little radiation to surrounding tissue. A much more penetrating particle is given off by yttrium-90. goes about 10 to 12 millimetres, and so there's a very large amount of radiation scattering around from those the cells that localise them, and nearby cells get quite a lot of radiation as well, and this can be problematic in terms of the toxicity to normal tissues, but is a very effective treatment if there's a very large tumour deposits, particularly if there's only a scattered or a smaller number of cells within each deposit which are giving up the radiation. In terms of identifying patients who are suitable for this therapy, the first and most important aspect is to try and demonstrate that the particular tumour deposits that we want to target have the receptor on their surface, and the best way to do that is with a scan. We've been using for many years indium-111 octreotide or octreoscan, but in recent times we've found that the use of PET with gallium-68 octreotide is actually much more sensitive at detecting deposits and characterising the expression of receptors on the surface. The octreotide has a higher binding potential to the receptors, and it's the agent that we use for therapy anyway, so it's good to use that diagnostically. And the advantage of PET is that it has very much more sensitive detection than the standard nuclear medicine test. And so the two pictures you see there are in fact the same patient, imaged 24 hours apart, on the left with the standard agent and the other one with the PET. And we, as I said, we found that is a really much more sensitive test. Unfortunately, the one on the left gets paid for by the government, the one on the right doesn't yet, but we're hopeful that we'll be able to convince them that it's good value for money to do the second test. The same thing applies when we're trying to use these radiopeptides for therapy. It's taking the radioactive chemical linked to the DOTA linker and the octreotide, fitting like a lock into the somatostatin receptor and delivering the isotope, either lutetium, indium, or yttrium, into the cell. We've been doing peptide receptor radionuclide therapy for about 15 years now. We started with indium-111. We've moved through various iterations, and the ones that we most commonly use now are lutetium-177 octreotide with chemotherapy, and also yttrium-90 in patients with large tumours or very large amount of tumours. As Katie pointed out, we pioneered the use of chemotherapy, which we know from external beam radiotherapy increases the sensitivity of tumours to radiation, and does that more effectively than it does to normal tumours. And so these two curves are showing the enhancement of radiation effect in terms of the number of tumours that are, or cells that are killed by radiation.
Rod, it's Kate speaking. I'm just letting you know we're just almost at the end of your allocated time. It's gone very fast. So maybe I know that you've probably got a little bit of content left to go. So perhaps you could maybe just pick a couple of things left to discuss before we move on to our next speaker. And I'm sorry to break in so rudely.
That's okay. No, I should have been keeping a better eye on the time. So we get these isotopes from internationally. They're flown to through Hong Kong to Melbourne, and we deliver the therapy either as or primarily as an outpatient, but sometimes if we're using indium, we use it as an inpatient. Get nice views from Peter Mackey. Unfortunately, not all of you will have access to nice views. In terms of the selection, the more intense the signal, the more likely patients are to respond. It's just simply a matter of how much dose of radiation we can get into them. Because it is a targeted therapy, we can see the effects. When we kill the cells that express the target, they should get less. And so this is a patient between July 2006 and March 2008 showing a marked reduction in sites of bony disease. With this therapy, we've given now over 700 doses of peptide receptor radionuclide therapy to patients around Australia, we see quite varying responses both between and within patients. And some patients, for example, will have much better response in their bone than in their soft tissue lesions. And even some soft tissue lesions, so the one circled, seems not to have responded as well as all the other ones, even though it definitely has responded. The other thing about this therapy is that the treatment can continue to have effects for many months after the treatment, and so this patient, through 4 cycles of treatment, had a marked reduction in the intensity and the extent of disease, but even 3 months following the treatment, a further regression of their disease, and that's relatively common. One of the important things to recognise is that these tumours are not all the same, that there is some variability in the biology of the disease. So the 2 top panels are looking at 2 different characteristics of the same tumour. On the left, looking at the somatostatin receptor, on the right, looking at glucose use, and the top tumour is not using glucose but does have the receptors. And so that's what we call a well-differentiated tumour, very like the cell from which it arose, whereas the bottom set of slices is a set of images of a large pancreatic tumour, of which a large proportion was using glucose and very little had the receptor, and so it's very to target that particular area of disease. And so this is, I guess, effectively my last slide too. There's a segue into the talk that Nick's going to give about the use of chemotherapy in these tumours. It's important to recognise that there is this variable level of differentiation from tumours which are very like the cells from which they came, and they're like the fruit in fruitcake. And there are areas which are very much more aggressive, more like a typical cancer, and that's the cake. And so the well-differentiated tumours, the ones that are primarily made of the cells that express the somatostatin receptor, are like a very rich fruitcake where the juice will seep out and permeate the cake, whereas the more aggressive tumours have only relatively smaller amounts of the well-differentiated, less aggressive parts of the cake and much more of the cake. And so it's much harder for the juice to get out in colour and permeate the cake. And we found over the years that depending on the proportions of each sort, we can get different results with different kinds of therapy. And so there's not, unfortunately, one size fits all with this disease. Some patients need chemotherapy, some need radiotherapy, many patients surgery can be helpful. It's also important to recognise that we treat patients, not scans, and often the aims of treatment, particularly in a slowly growing tumour, are to maintain the quality of life if patients are well, or to improve it if they're not, particularly to relieve hormone-related symptoms. To stop the tumour growing can be very beneficial if it's slowly growing in the first place. And shrinking tumours is less of important unless they're causing mechanical problems. So thanks, everyone, for your attention. I apologise for going over time.
Thank you so much, Rod. It's Kate speaking from the Cancer Council Victoria, and I'm sure everyone would join with me in thanking you so much for your time and for explaining what is really very complex. And I've got a nursing background, and I have to say, for me, there's so many new terms to take on, and I imagine that for someone who's diagnosed with a NET, this is a lot of information to take on. So thank you so much for your time this evening in presenting. What I'm going to do without further ado